Webinar number 13, Century Webinarathon, 1st December 2020 to 31st March 2021. Academy of Orthopedic Manual Physical Therapists, in its unique way of wishing the best new year as we unlock the COVID-19 and enter into the post-COVID era, as we fight in our unity to actually overcome the challenges posed in the past 8 to 9 months, and as we unlock our ignorance into the power of and the glory of knowledge. So it's always a great experience. It's a blessed experience to see that people are connected with the AOMPT, and they trust AOMPT in their what is called as the growth and the development of knowledge. So continuing after the two initial interruptions because of the internet connectivity, if there is an interruption now, assume that we will begin the webinar in Instagram. Okay, so I request our best members who are staying connected now to follow, keep track of this webinar on Instagram. Webinar number 13, Differential Diagnosis of Neck Pain. Neck pain is the second most commonest complaint for visiting a physical therapist, and differential diagnosis is something which is very important when we approach the patients when they come to us as a direct contact practitioner. The patient comes first to us before visiting the physician, so we need to know the differential diagnosis. If you are aiming for autonomy, we are aiming for professional identity, we need to upgrade our knowledge in differential diagnosis. Especially the communication with the interdisciplinary framework. For example, a physio communicating with an orthopedician should know the terminology in the orthopedics, the conditions which the surgeon usually uses the terminology. Okay, so that the communication will be much better. Our goals are always functional, and we are always going along the body structure function, the activity limitation, and the participation restriction, the international classification of functioning, disability and health, okay, ICF-DH model. So there may be markers in our clinical practice to identify impairment, or maybe a disability, or maybe a quality of life, or an handicap, which is called as the participation restrictions. So remember that differential diagnosis is important for these two purposes only. Okay, it's not going to guide the treatment, mainly because the terminology does not actually decide the treatment. Example for neck pain: if a patient has cervical spondylosis and then a patient has cervical radiculopathy, the treatment may not be different just because the patient is labeled as one of these conditions. The presentation is more important. The clinical presentation will indicate. And remember that cervical spondylosis does not mean the cervical spine is always stiff. Okay, it can be unstable also. It can be instability. It can be hypermobility. Stiffness can also be because of degeneration. Hypermobility can also be degeneration, caused by degeneration. A patient who is having neck pain and stiffness in the early morning when they wake up, and then with the pain is getting reduced. An early morning stiffness that is easing with the movements. It is highly suggestive of degenerative picture, which you might suggest that it is cervical spondylosis. But the range of motion restriction will be present in cervical spondylosis. In an acute stage, you will find degeneration of the joint leading to effusion. Okay, the synovial fluid will increase, especially facet joint degenerations in the cervical spine. Intervertebral disc degenerations also might cause a reactive, more what is called as inflammatory substances in the nucleus pulposus, okay, including the matrix metalloproteinases and the interleukins. So that kind of an inflammatory situation which increases the fluid, so you know that the picture is going to be, because the increased volume of fluid in the joint, the mobility will be excessive. But in the acute situation, if excessive mobility happens, pain will worsen. Okay? So the muscle spasm will set in. Because muscle spasm is there, range of motion is restricted. Okay? It's not because of the spondylosis that the stiffness is there, okay, in the acute stage. It is because degeneration, effusion is there. Effusion will cause hypermobility. Okay? Degeneration causing early morning stiffness, easing with movements. And then you see a spasm which is creating a picture of difficulty to move the neck. Okay? Subject turns like this. The other spectrum, the degeneration, inflammation has subsided. The initial stage has crossed. Patient has moved on now to a stage where they get only crepitus. Short sounds throughout the movement. So this picture shows that crepitus itself is a instability. The joint sounds are produced because of abnormal contact of the articular surfaces. Okay, excessive, what is called as alteration of the path of the instantaneous axis of rotation. Okay, every joint has an instantaneous axis of rotation. So there is a path of the instantaneous axis of rotation. That path, if it is altered, okay, in a three-dimensional, it might create a crepitus. So remember that stiffness or hypermobility, hypo or hyper, both can be present in spondylosis. In a patient who has stiffness, they will indicate the mobilization, whereas patient who have hypermobility, you will indicate a stabilization program. Stabilization in the end ranges, okay, if the movement is more, extension is more, okay, or the flexion is too much, if the range is increased, it's called as mechanical instability. In that scenario, you will prefer to use a soft cervical collar, so that the collar will limit the end of the range. Okay? You might expect the collar to work at least 3 weeks, so that the limited range, functional range, is the one which the joints will adapt to. Okay? During these 3 weeks, you have to get them into a conditioning program of muscles endurance, especially the stabilizer muscles. Other type of instability is the mid-range. Okay, not in the end ranges, but the ones in the mid-range. Okay, there the pain is coming, and this situation indicates that it is a clinical instability, which is because of the muscle control, motor control. So which might indicate a specific program of deep cervical short flexors endurance, co-activation with multifidus, and upper limb activation, or the temporomandibular or the tongue muscles activation, the coordinated muscle action, okay, in the cervical spine. So there you get a picture here now, until now, that differential diagnosis, what is the purpose, is not for treatment. Okay, it's only for communication and also for first contact practice, when we have to screen the related conditions and make sure that subject can have a spectrum of a presentation which is a combined picture of multiple disorders. Okay. In a cervical spondylosis, as I was telling about hypomobility, degeneration of the cervical spine always begins, okay, it's non-traumatic. Most of the time there is no trauma there. And if you see in terms of even a trivial trauma, small trauma, okay, it could be like a sudden turning of the head, for example, okay. Afterwards slight pain, then it went off. After 1 month again you are getting the pain, it goes after 1 day, okay. After 3 months again you get the neck pain, it goes after 1 week. It stays for 1 week and then goes. So longer, it started staying for longer time. Then you realize that the problem is increasing, it's worsening, okay. So then you are thinking of what is called as the initial trauma has created a degeneration, okay. Why am I talking about degeneration as first condition which you have to identify? Because all our atraumatic, okay, in our habits, our lifestyle, our nutrition, okay, right to do with the water intake, to do with the level of physical activity, the level of stress that everyone takes, always creates what is called as a premature aging, okay. So this begins from muscles, okay. The first structures to go for initial stage of degeneration is the muscles. So the picture could come as myofascial pain syndromes. Okay. When do you suspect a myofascial pain syndrome? When the patient actually has first onset neck pain. First time I am getting a neck pain. Before this I have not got neck pain at all. Okay. And the second picture is this neck pain is of a particular characteristic, like whenever I am in a sustained posture, in a particular position, a sustained activity, okay, after which I am having the pain. So my sustained one creates a contraction demand on the muscles for a longer period of time. So that is the picture where muscles can get affected. Don't expect that in a 30 minutes of sitting like this, my disc will go for degeneration. No. Okay. If the situation is only 3 months, I am sitting in an abnormal posture, it will be muscles only. But if I am sitting for 3 years, okay, if I am working in a bank, I am a bank employee, and I am always sitting like this, and I am, doing my laptop I am keeping, and I am doing like this, okay, or I am working from home, so I am using the smartphone, and I am always working like this, for example. In this scenario, 3 years, you can suspect definitely the changes to come to the joints and also to the bones. So get the picture right. When it is first onset, suspect the muscles. And of course, atraumatic. Okay, there should not be any trauma, sudden fall. For example, in sports also, or road traffic accidents. Okay, on field it is the sports one, on road it is the road traffic accidents. Okay, mainly the road traffic accidents causing neck pain is because of the helmet. People who don't wear helmets, they will get head injuries. Those who wear helmets will get neck pain. Okay, that is the whiplash injury, whiplash associated disorders. So it's a kind of a ligament injury. Okay, it is kind of a hyperextension, flexion, and then a hyperextension. Okay, like a whip. Okay, and then it is a ligament injury, predominantly leading to instability in the spine, cervical spine. Ligamentous instability, that means mechanical instability. Sometimes strain of upper cervical ligaments. Patient might have a referred headache. Whenever upper cervical spine or even cervical spine is involved, they have a tendency to produce a referred pain, headache. That is trauma. And then you see the other side of trauma, which is like fracture dislocations, where you have massive involvement, especially of the vertebra. Okay? You get a fracture, different types of fractures are there. Even in ligament sprains or strains, ligament sprain which happens in trauma, atraumatic ligament strain, okay, chronic episode. So remember that also has multiple ligaments that can go for injury. Anatomically, if you see, anterior longitudinal ligament, okay, annulus fibrosus is also a ligament, and then you come to the posterior longitudinal ligament, after which you come to, of course, the dura mater, but the dura mater is more considered as a neural structure under neurodynamics, neural mechanosensitivity, neural mobilization, neurodynamics. Okay, David Butler and Michael Shacklock, their concepts, or neuromanual therapy of the AOMPT. Okay, so you have these structures, then you have the ligamentum flavum, which is between the lamina, and then you have next interspinous, then supraspinous. In the neck, the supraspinous ligament is named as the ligamentum nuchae. Little bit laterally, you have the facet joint, so you have the facet joint capsule, and then the thickenings of the capsule anterior and posterior as the intervertebral ligaments, intertransverse ligaments. Okay. Leave all this with respect to the other cervical vertebrae, but upper cervical vertebrae has apical ligament, alar ligament, both the sides. Okay, it is like this on the dents, the odontoid process of the axis. This is apical ligament, this is right alar ligament, this is left alar ligament. Okay, and there is another which is called as the transverse ligament. Okay, the transverse ligament, which actually prevents the odontoid process to hit the spinal cord or the brainstem, which is behind. Okay, the transverse ligament of atlas. So remember that any of these multiple ligaments, it could be injured in isolation or in combination. Okay, so it's important to evaluate the stability tests for each of the ligaments. You might do a distraction, you might do a translation, you might do movement like lateral flexion or rotation, okay, in the upper cervical spine to check these ligaments after screening for sharp purser's test. Sharp purser's test is the special test for the transverse ligament instabilities. And of course, when the patient has any kind of an upper cervical problem, you diagnose whether it is upper cervical is involved or not. We have one test, clinical test, which is highly sensitive and specific, called as the Flexion rotation test. Okay, it is very useful test for cornering the upper cervical spine to be the source of the neck pain. Even we have a situation where headache can come from the neck. That headache mostly comes from upper cervical spine, which is called as cervicogenic headache. Okay. So you have neck pain here, you have headache here, same side. Headache never on the opposite side. Okay, only the same side as the neck pain. Always the neck pain comes first, then the headache comes next. Cervicogenic headache. It can be articular, it can be myofascial, or it can be neural. Okay. You have, other than this headache, is the giddiness, the dizziness, what the subject complains as, movement, a sensation of an imbalance, vertigo. Vertigo again has different differentiations, differential diagnosis. We discussed this. I am actually coming all these days now in the Century Webinarathon. It's an interactive webinar. I am not going into the details of actually describing all this because there are too much to actually concentrate for 1 hour. Okay. There is exclusive courses of the AOMPT which are video based courses. It's all my own teaching videos. You will find extraordinary in-depth demonstration and discussion on differential diagnosis using special tests, differentiation based examination in manual therapy. So various testing is there, and then we can also see, for example, how we can extend the diagnosis presentation into a biomechanical perspective, applying different types of manual therapy techniques, okay, for treatment. So that is also important. So all course videos comes with these certificates. So you should purchase those videos and try to get your better knowledge upgraded. You also get a lifetime membership of the AOMPT included in the fee. Okay, so don't miss this unique opportunity and learn from those videos during this time when you can dedicate it for learning. Okay. So cervicogenic headache, cervicogenic dizziness, or it could be even the dizziness itself could be because of vertebrobasilar insufficiency. There is no blood circulation going to the posterior part, basilar artery, which is formed by the two vertebral arteries, both the sides. Vertebrobasilar insufficiencies. which are presenting with 5 Ds, namely the dizziness, diplopia, double vision, okay, that is diplopia. Drop attacks, collapsing and then falling on the ground, a black screen sensation, and then the patient loses conscience, for example. That is the third D. And then the dysphagia and dysarthria are the other 2 Ds. Dysphagia has difficulty in swallowing, dysarthria has difficulty in articulation in the speech. Okay. Conversion of sound into words, that is articulation. VBI, after that, benign paroxysmal positional vertigo, which is from the vestibular apparatus. And also other types of vertigo may be the visual vertigo, when excessive lights are there or some movement of the vehicle. We close our eyes, we feel no giddiness. Okay, that is visual vertigo or motion sickness. Proprioceptive vertigo, it's called as the cervical vertigo or cervicogenic dizziness. We do the rotation and derotation test of the body and the neck. So then we identify that whether it is the cervicogenic vertigo. And treatment of the neck, you are giving mobilization or you are giving myofascial release, might reproduce the giddiness. Okay? And it will relieve the giddiness immediate post-treatment. Okay? So you know that the giddiness is caused because of referred autonomic impulses, okay, from the cervical spine structures. So as you have screened all this, cervicogenic headache, cervicogenic giddiness, dizziness, okay, cervicogenic vertigo, for example, and then the instabilities. After the instabilities, you have come to the whiplash, and then you have come to the myofascial pain syndrome. Okay. Next, you have come to the degeneration picture, where myofascial syndrome progressing to further degeneration, which may be hypomobility. There, facet joint degeneration is called as osteoarthritis of the spine. Disc degeneration is called as the degenerative disc disease. Okay. Both are degenerating, and it creates what is called as osteophytes from the facet joint, syndesmophytes from the intervertebral disc. They are encroaching the foramen, compressing on the nerve root from all the directions, will create, or the spinal cord also, stenosis. So the spinal stenosis can be central canal stenosis or foraminal stenosis. Foraminal stenosis is for the nerve root, it's a lower motor neuron presentation. Central stenosis is a spinal cord, it's upper motor neuron presentation. What do I mean by upper motor neuron and lower motor neuron? Is the clinical presentation of hyperreflexia, positive Babinski sign, balance, bladder and bowel involvement, bilateral upper and lower extremity, altered sensory or motor, okay, presentations. We'll say that it's an upper motor neuron, hyperreflexia. Okay, tone is more. After the shock, the tone increases, the stage of spinal shock. But if you see in terms of the LMN, the lower motor neuron, radiculopathy, it is more of unilateral, only upper limb. Okay. If it is LMN, all four limbs, it's very rare. Okay. So it's going to be only one upper extremity most of the times, or bilateral upper extremity. And you see in terms of reduced sensation, all these presentations, including hyporeflexia. In the stage of spinal shock, the hyporeflexia will be present in all four limbs. Okay. Spinal shock is differentiated by the bulbocavernosus reflex or the anal sphincter, okay, reflex, perianal sensation. Okay, so if that is intact, you can tell that spinal shock is crossed, okay, or not crossed. Okay, so you can identify by the presence or absence of the bulbocavernous reflex. Bulbocavernous reflex is absent, you can be sure that spinal shock is still going on. Okay, this especially the shock happens after trauma. Non-traumatic, it does not happen. Okay. So myelopathy, cervical myelopathy, that means it's the involvement of the spinal cord. Radiculopathy is the dysfunction or involvement of the nerve root. So stenosis can cause a radiculopathy. Only the syndesmophytes of the disc can cause a radiculopathy. Osteophytes of the facet joint alone can cause a radiculopathy. If it is facet joint that is causing the radiculopathy, extension with compression will be more painful. If it is the disc degeneration with the syndesmophytes causing radiculopathy, flexion and then compressions will be reproducing the radiating pain. Okay. If it is both the picture can coexist. Okay. So remember that the degenerative picture itself can be divided, and then it can come into a radiculopathy or a stenosis. And then you come to next progression where the degeneration has caused the disc material to come out of the annulus fibrosus. So that's where you have examples of disc bulge, disc protrusion, disc extrusion, and then disc sequestration. Okay. Different types of disc lesions. So that comes under the intervertebral disc prolapse. Okay. So there are a category of clinical presentations where you might have the patient into one part of the spectrum, whereas in another 2-3 days they can progress either to the previous or to the next level. Okay. Depending on the suitable or mismanagement. For example, if you did a mismanagement, they will worsen. Okay, they will develop the complication. The complication can be the sequel. Okay, the next disorder. A patient who is not having a radiating pain is coming only with the neck pain. After our physiotherapy, if they are having radiating pain, it shows that initially they had only spondylosis, but later they developed a radiculopathy. Okay, and after 1 month, if they are having balance problems, you should suspect that it's going to myelopathy. Okay, so remember that this spectrum is very, very dynamic. It depends on the homeostasis of the subject. Okay, how a person can actually adapt and also make sure that the internal systems of the body can recover from the initial insult. Okay, that is determined mainly by central nervous system, the past experiences, which can add on with central sensitization. And then the next one, of course, autonomic nervous system, which is the the primary defense mechanism, or the warrior, to fight anything abnormal that is there in the body. And then of course the next is you have the picture in terms of the combined factor of lifestyle, where physical activity, nutrition and stress. Okay, so all this determine the combined ones. Even the stress can have a cognitive affective influence. Okay, so patients can have psychogenic or fear avoidance beliefs too much, and they might even pretend to be having neck pain sometimes when they even don't have neck pain. Okay, just for a benefit. So we have covered all these aspects in different parts of previous webinars, also in AOMPT, both in free webinars and also in the paid courses. So understand this differential diagnosis is a continuous, it's a continuum. Okay, you can't tell that there is one diagnosis and that one diagnosis only is the end. No, it's not the end. It just tells at one position or one point in the spectrum. Patient can shift to any point of the spectrum anytime. Okay. And spondylolisthesis, we are talking about the slipping of vertebra over the other vertebra. It's very rare in the cervical spine. But if you wish to include then degeneration, we are talking about facet joint and disc. If the degeneration happens in pars interarticularis, the portion of the bone between the superior articulating process and the inferior articulating process, they form the facet joint. Between that is the pars interarticularis. If this goes for degeneration, it's called as degenerative or spondylolysis. Okay. After that lysis, the vertebra is prone for listhesis, degenerative spondylolisthesis. Listhesis again has subtypes which may be differentially diagnosed with X-ray. Okay. Grade 1, 2, 3, 4, depending on the level of slip, how much the slip, 25%, 25 to 50, 50 to 75, 100%. If the whole vertebra is drops in front of the lower vertebra, it's called as spondylotosis. If the slip is backward, retrolisthesis. Okay. All these are the types are differential diagnosis. Okay. You have and also the related conditions are differential diagnosis. Okay. Etiology can be differential diagnosis. Okay. Myofascial pain syndrome. In that muscles, you have levator scapulae, versus upper trapezius. That's a differential diagnosis. In a myofascial dysfunction, a spasm versus adhesions versus shortening or tightness versus trigger points, okay, and also contractures. Okay? That is again a differential diagnosis. So you can diagnose spasm, but spasm is a sign. Okay, spasm, adhesion, shortening, whatever I was talking now, these are all clinical signs, they are not diagnosis. But between them also you will see the picture will shift. Initially spasm may be there, later they will go to contracture if ignored. Okay. Articular dysfunctions can range from hypermobility initially or hypomobility later, ankylosed. And then articular dysfunctions can also come acute episodes. Sometimes the articular dysfunctions can come with locking of the facet joint. In the neck, we have the locking of the neck, which is called as wry neck, okay, WRY, acute wry neck, which is articular wry neck and myofascial wry neck. Myofascial wry neck is sternocleidomastoid going for a spasm. So it's got stretched, okay, sudden stretch, sudden contraction, someone is going there, you were turning and seeing, and after that you are coming back, you are like, okay, holding it, and after that if somebody is calling you that side, you will what happened, okay, yeah, what happened, okay, the torticollis comes and you are not able to move the neck, right? It's predominantly muscular. Sometimes the facet joint lock will come. That comes with you are lying down prone, and then you are keeping the head like this, and then you slept. Morning you wake up, your neck is like this. Somebody calls here, you are not able to turn. Someone calls here, you are not able to turn. Okay, and you are like pain. Okay, so that is articular wry neck. Articular wry neck, the locked facet comes after sleeping position. Throughout the night you might have slept in the wrong position. Myofascial wry neck comes with a sudden contraction. Okay, either in the innermost range or outermost. Of the webinar number 13, differential diagnosis of neck pain. The concluding moments. I just have some 5 minutes now. So after cervical radiculopathy, we're talking about a neurological condition with neural mechanosensitivity, where neurodynamic tests are abnormal, nerve palpation is abnormal. It can happen in brachial plexus injuries that can present with neck pain. Brachial plexus injuries have subtypes like Erb's, Klumpke's, okay, upper or the lower trunk. Plexopathies are common with even peripheral neuropathies, okay, which can come with pain. I forgot to tell you about the central nervous system disorder which has a pain, that is multiple sclerosis. It has neck pain, electrical sensation, Lermite sign. Okay. So there are presentations in neurological conditions also which can come with neck pain. And then you see in terms of cervicobrachial pain syndromes, they are very minor conditions, not major in terms of complications, but they are associated with hypomobility in the articular and also the neural systems, where the neck and arm pain is reproduced by. So cervicobrachial pain syndrome is a very important condition which you should not forget. Patients will respond with lateral glide and also mobilizations to the cervical spine, myofascial treatments to the neck, and neurodynamics to the upper limb. Okay. Last condition is thoracic outlet syndrome, where you have again 4 types: cervical rib syndrome, scalenus anticus syndrome, costoclavicular syndrome, and the pectoralis minor syndrome. Okay, 4 levels. So you can diagnose them either by radiology or by combination of breathing, for example, scalenus anticus syndrome. Neck rotations will check the cervical rib, and you have shoulder girdle elevation depression, that will check the costoclavicular syndrome, and protraction retraction will check the pectoralis minor during the AdSense test, when you palpate the pulse and then you keep the arm extended. So AdSense test itself. So different components of the AdSense test itself, you can differentially diagnose the subtypes of thoracic outlet syndrome. So I would request all the participants who are watching this webinar